up. I'm out of bed. It's a good day.
Good for your father. Hopefully the world's a little more optimistic than that.
Oh no, he meant that with pure optimism. He was like, "Hey, it's better than the alternative. I'm up.
No, I
Doing good."
I understand. Do we have folks? How many folks do we have on? Obviously at this point, because obviously the most important folks are our new members for this particular. I see Greg. I see Elizabeth. And I want to thank both of you. We should have two other new members on shortly, hopefully. Greg, you're muted.
I didn't have anything important to say, so I was just
yeah, I was muted.
Hey, Greg.
Yeah, I was gonna tell Karen and you that I joined the June. I tried to get on the June meeting and realized this wasn't June yet. This is still April.
you have been accused of being a visionary, Greg.
That's right. Well, yeah, Brooke included all those different emails, and I hit the wrong one.
Oh, how are you doing this morning, Greg? It's great to hear your voice.
How about you, Karen?
Doing all right. Doing okay. Thank you
Good.
for asking.
Good.
Yeah. And obviously the orientation will be focused, the retreat will be focused. It will give us an opportunity to focus on what we think our role should be in the process. Hopefully that'll be a really productive day. And Elizabeth, thank you for joining.
I'm sorry, Michael, but Brooke, it looks like just got a text from Lauren. She seems to be having some trouble logging in. Lauren Walker, so I'm not sure.
Several people saying they don't have the link. I'm trying to email it to them now.
Oh, okay. Yeah,
I just put Lauren in as a panelist.
Okay, thank you. Because I remember when I went in on the calendar, and it kept looping me back, trying to get me to re-register. And so I finally went a different way, and so I'm not sure.
It's really strange that everybody's saying they don't have the link, because it comes out in the calendar.
It doesn't come up. It didn't come up in my calendar, Brooke. I don't understand, but
I don't either, because I mean it's WebEx.
Yeah, I don't get it. We can follow up and ask that question later.
Yeah.
Okay. Dr. Cook is with us. So we're up to 4 board members.
Our newest member will not be attending. I don't believe I told her I would email her, and Kanan will not be on.
Yeah, the most important people are the new folks, and I believe Ashley's now on. I believe Elizabeth is on, and Greg is on. And I think for this event, they're probably the most important people. For anybody else on the phone, by the way, we had a new member appointed on Friday, so she just got apparently just got notice of this either Monday or I think it was Monday. Obviously, that could create a fair difficulty for her on her calendar. But Karen, what do you think? Should we get started?
I think it's good to go ahead and get started at this point. And then if folks join us a little bit late, then we'll be happy to have them then.
Yeah. I think you've got for this event, I think you've got the most important people here.
Okay. So you ready for us to get started, Michael?
I am, if you guys are, and if Greg and Elizabeth and Ashley are.
Sure. Yeah, it sounds good.
All right.
Yeah, I'm ready. Thank you.
Hey there. Good morning, Mr. Chairman and members of our board. It's a pleasure to have you here this morning. I'm Karen Kimsey. I'm the director of the Department of Medical Assistance Services, and I think it'd be great just to do a quick round robin on our piece, and maybe you can, if you have it on the list, you can just have people go through, and then we can say who we are. And if you're at the agency with DMAS, just say what your title is and what you oversee. And then if you're a new board members, then I'd love to hear your background a little bit and what's of interest to you as well. Just a tiny little blurb on that for Medicaid. So it'd be helpful. So Brooke, if you could help us by start going down, and you could start the DMAS stuff if you want.
Sure. Ashley Gray.
Hi, everybody.
You're mute.
Hi, can you hear me?
Yes, yes.
Hi, everybody. Ashley Gray, new board member, also very familiar face to Medicaid. I've spent some time over the years in the Medicaid managed care space, but always focused on the ways in which we serve beneficiaries from the industry perspective. I am now at the MITRE Corporation, where I work, unsurprisingly, on Medicaid issues. So rulemaking for Medicaid, programs dealing with equity for Medicaid, social determinants of health. So all of this is sort of in my wheelhouse. In terms of areas that I'm really interested in, it's really the beneficiary experience, including them in decision making. I have a passion for addressing health equity issues and maternal child health and things like that. So I'm always happy to get involved and to be of service in those discussions. But that's a little bit about me.
Great, Ashley. Thank you and welcome.
All right. Next, Elizabeth Coulter.
Oh, Mike. Brooke, I'm sorry. Hold
No,
on. Elizabeth, before we
Was
talk,
just
Michael
ask
had
Brooke to move on. Just to ask,
okay.
just ask Brooke to move on. That's a.
Go ahead.
Hi, I'm Elizabeth Coulter. Can you hear me?
Yep.
Okay.
Yes.
All right. Great. Sorry, I usually don't use WebEx, so this is a new system for me. So I'm learning it with this meeting and the previous ones. But yeah, so I'm Elizabeth Coulter. I worked as a teacher and then decided to become an advocate shortly after my son was diagnosed with special needs. He has a very rare condition that's genetic, and he kind of got me immersed into the special needs landscape. I worked as an advocate as well in Baltimore City and Howard County, a few other counties in Maryland, as well as Prince William County, and I'm trying to remember the other one I worked with pre-COVID. And it really got me involved with the community and a lot of the people in the special needs circles. We were unfortunately, we had rough experiences trying to get any kind of services for my son in Maryland. So we moved to Virginia, and that's why we came down here. And really looking just to improve the system from a personal standpoint and from local voices.
Oh, thank you, Elizabeth, and welcome. Love to have your voice here on the board.
Thank you.
Next, Greg Peters.
Yes, I'm Greg Peters. I'm just recently retired as the CEO of United Methodist Family Services and Charter Health School and Guardian Place. Had 3 corporations that worked with seniors, and there were 2 nonprofits and 1 for-profit that worked all throughout the state of Virginia, and been very involved with behavioral health care, and probably been involved with DMAS, I guess, since the mid-80s. Was on a lot of committees, was on the first committee that actually brought residential care and some of the other programs into Medicaid so many years ago. A lot of my time has been with advocating for children and families. And one of the ways I did that, I was appointed by, the last 5 governors, including Governor Northam, to be on the State Executive Council for the Children's Services Act. And so I got to know Karen and Cindy Jones really well, as all the commissioners for the different programs were on there. And our organization had been real involved in developing systems of care throughout the state and best practices with children aging out of foster care. So a number of the clients we served, particularly children, were receiving Medicaid. And so a lot of my interest has been, as I was listening to Elizabeth, one of the things we did, and we did with DMAS, was create a program for family support partners where a Medicaid waiver was done some years ago. And it was after we had a parent support partner actually talk to the State Executive Council, and Cindy came to me after the meeting and said, we don't think we have this yet, and we're interested in it. And they had peer support for adults, but not for families. And so that's one of the things we did as a joint partnership to help develop with DMAS. So that was one of the things I was really proud of that we worked on together.
Mm-hmm. Well, thank you, Greg. Oh, go ahead, Greg. Keep going.
Yeah, I said I'm retired, Karen, but I'm still fundraising for United Methodist, and I'm doing a lot of gardening. And now I'm raising a granddaughter that with her, my son and daughter-in-law in the area. So my wife and I are keeping real busy with her, and she'll be with us tomorrow. So that's been a joy.
Oh, great. Well, congratulations on the grandbaby, and also welcome. And we appreciate all of your background and knowledge and look forward to having you as well on the board.
Thank you.
All right, next is Patricia Cook.
Patricia, I think you're on mute.
See. Is that better? Can you hear me now?
Yep.
Yes.
All right, good. Okay. So I am Patricia Cook. I'm the Chief Medical Officer at Daily Planet Healthcare Services, and that is here in Richmond. We are a federally qualified healthcare for the homeless center. I practice internal medicine and pediatrics in addition to administering this place. I joined the board a couple years ago. I just got reappointed again recently. And the things that brought me to the board were my interest in taking care of people that were generally underserved as a practitioner. So I'm a provider member of the board. But I also have a personal interest in that I have 4 special needs grandchildren. 3 of them were adopted from the foster care system here in Virginia. So all of my grandkids have Medicaid, and it's important to me that things work right for them as well as for the diverse population that I serve here.
Thank you, Dr. Cook, and welcome to our orientation. It's a pleasure to have you again on our board.
All right, next is Dr. Ali.
Hello, everybody. So my name is Razi. My background
Razi, we've lost the ability to be able to hear you.
Rosie, we're not hearing right now.
It looks like he's.
I think, did we lose him?
I think it,
On,
we might have.
we've lost your sound, Rosie. I think you've got a rough connection there. Can you hold your hand up if Karen, I think we've lost Rosie. Do you want to go on to Brooke? Do you want to go on to the next person? Then we can bring Rosie back in right after that.
You would be next, Michael.
My condolences to everybody else then. Listening. My name is Michael Cook. I've been on the board since 2015, appointed by Governor McAuliffe. I've been a healthcare lawyer since, of all things, 1973, when I started out as a lawyer for the Medicaid, AFDC, and Medicare programs for the feds in the Office of General Counsel. I screwed up the system enough that I got a position in private practice starting in 1981 to try and fix it, and I've been representing healthcare providers, practitioners in a wide variety of fields since then, with both large firms and then now with a smaller one. Probably more directly, I've been fortunate to be. I probably worked with state Medicaid programs in over 40 states during that career, which only tells you my age. And I've served as a policy advisor for Governor McAuliffe's campaign, Governor Kane's Health Reform Commission and campaign, and Governor Northam's campaign, and also on their transition teams, worked on the health policy teams for the Biden and Clinton campaigns. Probably most relevant. I was when I was in law school, I was a summer law student working on a law student civil rights research council grant in Philadelphia, and then worked for legal services, storefront law office, my second year. And I owe those folks an awful lot for teaching me what life was about for people who don't have substantial incomes, and also working on the board of foster care of a program that partners with universities to try and prepare foster kids for colleges and universities and post-high school life. My passion is coverage and making sure that healthcare, doing whatever I can to provide, make sure that healthcare is available to everyone. I have a son who has had substantial health issues through his life, and right now also on the social determinants.
Thank you, Michael. Welcome as our chair. So Brooke, is it? I'm just to let our team run through.
That's all of the board members.
Okay. Well, I'll turn it over if you could just call our team. Yeah.
Yeah, sure. Cheryl Roberts.
Trying to say hello. Hi, I'm Cheryl Roberts. I'm the Deputy for Program and Operations. That means the claims and stuff, the things that you do in the beginning. The program integrity is what we do in the end to make sure things are proper, and dental, and as well as handling the Medallion 4 population, which is our more mobile population, women, children, mostly the Medicaid expansion population.
All right, next is Chris Gordon.
Good morning. My name is Chris Gordon. I'm the Chief Financial Officer for DMAS.
And Chris also oversees the IM sections and IT sections of our agency as well. Okay, thanks, Chris.
I think we're losing him. I think we're having some difficulties with the bandwidth.
You can go to You can go to the next person. It's fine.
Okay,
Chris looks
Christina
like
Knuckles.
Yeah.
Good morning. I'm Christina Knuckles, and I'm the Director of Strategic Communications.
Craig Markfa.
Hello, I'm Craig Markfa. I'm work in the Office of Communication Legislation Administration, and Brooke and I work directly with the board. So it's a pleasure to be here with you this morning. And I just want to remind everybody, this is being recorded and it will be safe for posterity and for further use. So it is a public meeting. And so I don't know how many people are currently listening on the public, but it will be available for public consumption. So just we're going to try to keep this within the 2 hours, and we will be able to obviously try to answer questions as we go along. But if we need to get to the end, and we can always do follow-up with individual board members, and this is just a continuing process. So we will be happy to fill in the blanks in the future if there's not enough time to cover it today. Thank you.
Next is Lauren Walker.
Hi, everybody. I'm Lauren Walker. I'm the Acting Chief Health Economist, which is the Deputy for Health Economics and Economic Policy. So we have data analytics, quality, population health, and value-based purchasing in our area. And I'm acting for Ellen Moss, who will typically be on these meetings, but she's out at the moment.
Okay, next is Sarah Hatton.
Hi, good morning, everyone. Sarah Hatton. I'm the Deputy for Administration. That includes our Eligibility and Enrollment Services, which is over our Cover Virginia Call Center for the state, the Appeals Division, our Policy Divisions, Legislative Affairs, and Outreach and Member Engagement.
And lastly is Tammy Whitlock.
Good morning, everybody. I'm the Deputy for Complex Care and Services here at DMAS, and I oversee all of long-term care, behavioral health, and our managed long-term services and supports product in managed care, CCC+.
Thanks, team. And also want to recognize one. Thank you, Brooke. And also want to recognize one more person. Our Chief of Staff, Ivory Banks, is out on today celebrating her birthday. So we have Miss Sarah Broughton here to represent the Office of Chief of Staff. And I think, Brooke, she's listed as an attendee, but if you want to pull her to panelist, then she can help answer any questions related to that office.
Yes.
So thank you.
Sure, I just pulled her in as a panelist, so.
Thank you. All right, I think we're good to go with presentations and ready to get started, right?
Yes, we are.
All right. Okay. So what we've done for our board members is we've got a nice presentation for you. And as Craig had said, we have quite a bit to share with you, but we love ongoing discussion. So if you want to ask questions, please feel free. The team and I have split up the presentation itself. So you won't just have to look at one of us the whole time. So you'll get the mixed variety and also expertise of the team and our conversations, but please feel free to ask questions along the way as we get started. So on the next slide, I'll just do a quick introduction to it, and then I'll turn it over to the team. You'll see on our agenda for you that it's pretty packed, that we today are going to give you an overview of Medicaid overall, and then talk to you in detail about the types of benefits that we offer here at the program that serves 1 in 5 Virginians. Very, very proud of that, 1.8 million human lives. Funding, we're going to talk about the money, which is very important. We're now the largest spender of the Commonwealth's budget. And so it's very, very important for us to be mindful and great public stewards of taxpayer dollars. Also, we're going to talk to you about our priority initiatives, other types of important things that we're doing to communicate and get the word out about all the great things happening here at Medicaid, and then also just some other pieces for you. So I'm going to go ahead and turn it over to the team to get started.
Karen, real quick, I just want to let you know that Davis Cree from the OAG's office is online. For some reason, I'm unable to make him a panelist.
Oh, okay. Well, welcome. I just wanted to shout out to Davis Creep, who is a representative from the Attorney General's office. You will get to know him and also see him at our board meetings. So welcome, Davis. We're glad to have you here joining us today. And if you need anything, just text. You can text me privately in the Q&A in the chat section or anything if you need us to relay something or something to Brooke as well.
Yeah, I was going to suggest that if you want to submit a question in the Q&A, it'll help move things along. We only have 90 minutes left here, so we need to get moving here. So Brooke, let's move to the next slide. And
okay, good morning, everyone. Again, I'm Sarah Hatton. I am going to kick off the presentation and just talk to you a little bit about the basics of Medicaid and eligibility and our agency. So to start us off, the DMAS mission statement is to improve the health and well-being of Virginians through access to high-quality health care coverage. Our mission statement at DMAS is applied to all of the work of the agency, and DMAS plays an important role in helping the agency to support this mission. Our DMAS values are service collaboration, trust, adaptability, and problem solving. And each of these values complement our mission statement in providing high quality health coverage. The teams within our agency, they all work really hard to collaborate, problem solve, build a culture of trust, and embrace change to provide the best possible service to those who are touched by the Virginia Medicaid program. Next slide. Okay, here we have our current agency org chart. As you can see, there are many divisions that work together to administer the Virginia Medicaid program. Our agency director, Karen Kimsey, has direct oversight of 7 members of the executive leadership team, or the ELT, all folks that have introduced themselves this morning. And so those people include the chief deputy, the chief of staff, the chief medical officer, the deputy for finance and technology, the deputy for administration, the deputy for programs, the deputy for complex care services. And each member of ELT provides leadership to the many divisions which fall under their umbrella. Appendix A, which is at the end of today's presentation, provides a description for each of the divisions and their primary functions and responsibilities within the agency. Next slide, Brooke. So the Centers for Medicare and Medicaid Services, or CMS, is responsible for the administration of the Medicaid program at the federal level. And federal law requires that each state designate a single state agency to administer its Medicaid program. And in Virginia, DMAS is the single state agency. Section 1902 of the Social Security Act requires that states have a state plan that demonstrates an understanding of all of the federal Medicaid requirements. But prior to making any program modifications, we are required to submit a state plan amendment, or a SPA, to CMS for review and approval. In addition to SPAs, CMS also oversees the approval of waivers and provides guidance to states. Next slide. So under a waiver, a state can waive certain Medicaid program requirements to allow the state to provide care that may otherwise not be eligible under Medicaid. Waivers can generally be classified into 2 categories: research and demonstration, which allow a state to test a new or existing approach to program financing, and then program waivers, which are intended to expand the array of defined program options available to a state. And so in exchange for the flexibility that is offered by the waivers, Virginia generally has to meet budgetary criteria and provide regular reports and evaluations to CMS to show that the requirements of the waiver are being met. So unlike most state plan options, waivers require pretty lengthy applications and they must be renewed periodically. Next slide. And so here we have some different types of waivers. So section 1115, I'll start with that one, states that are seeking additional flexibility in the design of their Medicaid programs can apply for formal waivers of some of the statutory requirements from the Secretary of HHS. And they can also use waivers to respond to disasters and public health emergencies. Waivers are generally referred to by the section of the Social Security Act granting the waiver authority. So 1915B, for example, is also called the Freedom of Choice Waiver, and 1915C, which are the Home and Community-Based Services waivers, are both examples of program waivers. 1115 is an example of a research and demonstration waiver, and under those, the Secretary can waive almost any Medicaid state plan requirement to the extent necessary to carry out a demonstration or experimental project to further the goals of the Medicaid program. 1332 are state innovation waivers, allow states to pursue innovative strategies for providing their residents with high quality, affordable health insurance while still retaining all of the basic protections of the Affordable Care Act. And then finally, we have our 1135 waivers, which those occur when the Secretary of HHS temporarily modifies or waives certain Medicaid or CHIP requirements, and those are generally related to disasters or emergencies. Next slide. So Virginia Medicaid provides health coverage to families and children, pregnant women, the elderly, people with disabilities, and adults that are below a certain income level. Due to Medicaid expansion, more Virginians than ever are now eligible for health coverage through Virginia Medicaid. And since January 1st, 2019, which is when expansion was implemented, over 500,000 adults have gained access to needed medical care. As Karen mentioned, this is the highest number of Medicaid members in the history of Virginia's Medicaid program. 1 out of 5 Virginians have access to health coverage through Medicaid now. Next slide. So this chart represents an example of income guidelines to meet the requirements for Virginia Medicaid. Financial requirements when applying for Medicaid include a review of income, and for certain populations, a review of resources. Household income is compared to the federal poverty level in order to determine their eligibility for Medicaid. And that federal poverty level is updated each year by HHS to determine eligibility for certain programs and benefits. In addition to those financial requirements, which I mentioned could be income and or resources, individuals are also required to meet non-financial requirements, such as Virginia residency, in order to be eligible for Medicaid. Next slide. So this is just a little snapshot of how people can apply for Medicaid. Virginians can file telephonic applications by calling Cover Virginia, which is our state Medicaid call center. They can apply online through Common Help, which also allows applicants to apply for other public assistance programs that are offered through the Department of Social Services. They can apply through healthcare.gov, which is the health insurance marketplace. They can apply using a paper application and send it in through the mail, or they can apply in person at their local Department of Social Services. Next slide. So as I mentioned earlier, this is a nice breakdown of how our population falls out between the different categories of individuals. 1 out of 5 Virginians have access to health coverage through Medicaid. And you'll see here the numbers for expansion. Over 500,000 adults have this access to no-cost health coverage during the public health emergency, which is really important. All of this data that's here is also available on our public dashboards. Those can be found on our DMAS website. It's a great tool to be able to go and look at our numbers throughout the year. And as another note, just to explain the other adults category that's at the bottom of this list. So these are our low-income adults and parents. They're individuals who are under the age of 65 and not disabled, but they were eligible for expansion due to their income and parental status prior to Medicaid expansion. Next slide. So, and when we expanded Medicaid in 2019 to adults between the ages of 19 and 64, that was for folks earning up to 138% of the federal poverty level. Prior to us doing that, coverage for adults in this age group was only available to qualifying parents, pregnant women, or individuals who had been determined disabled. So expansion was really critical for Virginians who worked in fields like retail, food service, landscaping, other types of careers that did not offer health insurance to them. So in addition to primary doctor and hospital and emergency services, these individuals then were able to gain access to benefits like smoking cessation and nutritional counseling, transportation to medical appointments, and laboratory and x-ray services. Next slide. So prior to expanding Medicaid to adults between the ages of 19 and 64, on the left side here, you'll see 62% of Virginians didn't receive needed medical care. And many had conditions that prevented them from being able to obtain employment, even part-time employment. And on the other side, you'll see since that time, well, this was a year after Medicaid expansion, over 60% of individuals that were enrolled in Medicaid expansion had a general office visit, and more than 80% of them who were enrolled had received at least one service through Medicaid. Next slide, please. And so the previous slide, as I mentioned, it reflected access to care 1 year after Medicaid expansion was implemented. But since that time, so that puts us to the beginning of 2020. And so as you know, since that time, Medicaid has played a really critical role in the lives of tens of thousands of individuals who then applied for Medicaid during the health crisis. Many of those folks had lost their jobs or had changes in circumstances due to the pandemic, like a loss of hours or loss of income. And because of Medicaid expansion during this pandemic, these newly eligible adults have coverage for COVID-19 testing and treatment, as well as treatment for chronic conditions that worsen the effects of the virus. Those include diabetes and cancer, chronic obstructive pulmonary disorder, high blood pressure, asthma. All of this just shows even further the importance of Medicaid right now, especially during the public health emergency and the importance of Medicaid expansion. And I think that was my last slide, Brooke. It was. So I will turn the mic over to Tammy Whitlock, our Deputy for Complex Care.
All right. Thank you, Sarah.
Karen, just a quick question for you. Will you be addressing the fact that we are now going to be covering dental care at some point for adults? Will somebody, I'll shut my mouth if that's the case.
Yeah, Michael, it's a little bit on mine. Yeah.
Great.
But also, Cheryl reminded me that she is there. There's a presentation to BMAS on dental at the next meeting.
Great.
Yeah, I think that's the best place, Michael, because Tammy's going to fly through it, but you're going to want to know things like the details of the benefits, and I think it's best if we do it at BMAS.
Great. Thanks.
Yeah.
Thanks, Cheryl.
Okay, next slide, or first slide for me, I guess. So as people have talked about, we have a lot of services that we cover at Medicaid. And this is what you see on the slide is a snapshot of them. And I'm going to go through these and then talk a little bit more about what our service model looks like and our delivery system looks like, just to give an overview. But we are happy to answer any other specific questions that anyone has about what we cover and what we don't cover. So primary care, of course, going to your doctor's offices, going for preventive services, child care, child preventive services, all of those services are covered at the physician's office. Well child visits are especially important to us and to the maternal child health piece of Medicaid. Acute care would include inpatient services at a hospital. Other types of acute care that run into behavioral health are things like our residential treatment program that for kids that have inpatient psychiatric services for our kids in a residential type setting where they still go to school and they still get other counseling and things like that, but that is also a covered service. Behavioral health is a big covered service for us, certainly in my area, and you're going to hear a little bit more about our new behavioral health evidence-based services that are coming online starting in July. Karen, I think, is going to talk about that, called Bravo. And right now, we already cover inpatient services for behavioral health, outpatient counseling, other outpatient services for behavioral health, And then a large portion of our behavioral health coverage is in our what we call community mental health and rehab services that are basically mostly done by our private providers. A lot of people think that our community services boards do a lot of our behavioral health services, and they don't. They do about 20 to 24% of our behavioral health services, especially the community mental health, and most of these services are actually performed by our private providers throughout the state. Addiction and recovery services. If you've been around DMAS in the last few years or heard anything about DMAS, not yet. Let's go back to the other one. Thanks. Arts benefit is what you'll hear us talk about. We started that in 2017. It was a wonderful effort that we did across agencies, across a lot of providers, and we saw a huge benefit in increasing our rates as well as increasing the number of providers who now participate in Medicaid strictly for the arts benefit. And in the last session, we've seen some different things added to the arts benefit to be able to go beyond opioid treatment. There's very exciting things coming in arts, and so that's definitely a program that we are very proud of, and it has helped an awful lot of people just in the 3.5 years it's been operational. Long-term services and supports is an area near and dear to my heart and Karen's, I will say. We started out in long-term care, so we have a plethora, I would call it, of long-term care services and supports, starting from, of course, inpatient nursing home care that is obviously a level of care that is needed in some cases, down to PACE, which we, the Program for All-Inclusive Care throughout the state. We have those sites. If you've never been to a PACE site, I encourage you to go. It's really cool. You can see where people come into those sites and they get everything they need at that site. And if they can't come in, then the PACE sites actually go out to the home and provide services. It's a really wonderful model. And then we have, Sarah talked about the 1915C waivers. So if you hear us say it's a C waiver, then it is a home and community-based waiver. And I have a slide on that in a minute that I'll talk about our waivers that fall into that category. Pharmacy, of course, is a big area that in healthcare in general. And we actually have some interesting, we started something a few years ago where we have a common care formulary, a common core formulary. So all of our health plans have to cover at least what is on our formulary. They can go beyond it, but they can't go less. So that was a new thing that we did a few years ago. But pharmacy is a big covered service and a lot of utilization in our pharmacy area, obviously. Dental, we talked about. Cheryl's going to present on that at the next DMAS meeting, but we're extremely excited that we get to start providing coverage for our adults. We've been doing kids as far as dental, but now on July 1st, we get to provide coverage for adults for dental. And that's just, that is, as long as I've been at DMAS, was a long time, we've been trying to get dental into our coverage system. And this is extremely exciting for everyone, including, most importantly, our members. Next slide. So what does our delivery system look like? So you may hear concepts or acronyms and things like this. So I want to explain fee for service. Sometimes when you see our reports, you'll see FFS versus MCO or managed care. And what that means is DMAS used to have a pretty large fee for service program until 2017, when we switched over and moved many services, including a lot of our long-term care services and behavioral health services, into managed care. So fee for service just basically means it still covers all of the Medicaid services, all of the eligible services. Anybody who's eligible for Medicaid and is in fee for service gets all of our state plan services and is eligible to get our waiver services. But the state pays those, we pay those providers directly to provide specific services. So when you move to managed care, you have a different type of arrangement. It's a risk-based model where DMAS actually pays the managed care entities per member per month, and they take care of all the needs of that member for that per member per month. We do have a few things that are still what we call carved out of managed care, but not very many. And I think the last time, I know Lauren's on, she'll correct me, but I think the last time we checked, We're about 93, 94% managed care, if not a little bit more than that. We have a very small fee-for-service group still left in that's outside of managed care. Next slide. So the transition to managed care. We've had Medallion for over 20 years, and the Medallion program, as many of you are familiar with, serves infants, children, pregnant women, and now includes the adults on Medicaid expansion who don't fall into a category that would shift them over to CCC Plus. It covers, Medallion covers all of the basic services. It does not cover, excludes long-term services and supports, but covers all the behavioral health, all the arts services, everything like that. Long-term services and supports are totally in CCC Plus. So if you think about when you're looking at our populations, if you have somebody who's in a nursing home or somebody's in a waiver, you automatically know they're in CCC Plus if they're in managed care. So when you look at CCC Plus, we do serve older adults and disabled individuals who are on waivers, who are in nursing homes. The ABD population that Sarah talked about earlier, those individuals are in CCC Plus, and our duals are in CCC Plus. So the individuals who have Medicare and Medicaid are also served in CCC Plus. It is the same scope of treatment, same scope of services that are available through Medallion, with the addition of long-term services and support. So all of our waivers, hospice, and nursing homes and things like that are covered in CCC Plus. We started statewide for CCC Plus in January of 2018, and then you'll note that Medallion followed up in August of 2018 for Medallion 4, where that program was reprocured and came into operation in August of 2018. So pretty close, within 6 months of each other. Next slide. So waivers. Sometimes this is a very confusing area for people. You know, when I used to work in long-term care, people would say waivers and they would glaze over and just not want to talk about waivers at all, because sometimes it's confusing to people to think that there's a separate, they think it's a separate, complete separate program, and it kind of is. So we have 4 waivers at DMAS under the 1915C category. If you think about, if you're familiar with DD or the DD waivers, we used to have 1. We moved to 3 different DD waivers. So we have the community living waiver, the family and individual supports waiver, and then the building independence waiver. And each of those waivers have different goals for their members. So if you have someone who is ready to get out into the community and live on their own, they're going to be in the building independence waiver. You know, if you have somebody who needs 24/7 services, they're going to be more towards the community living waiver. So there are different scales and different levels of funding that's available for those waivers. And so, and I would say a plethora, more than a plethora of services available. And we do have some fact sheets on these waivers. If anybody's interested, I'm happy to send them through to Brooke and she can send those out to you if you're interested in seeing those. The CCC Plus waiver, this used to be called, if you've been around Medicaid for a while, you probably remember what we used to call the EDCD waiver and our tech waiver. So what we did when the CCC Plus managed care product came into fruition, we combined those 2 waivers and we made it one waiver and called it CCC Plus. So that waiver is our largest waiver, and it does incorporate individuals who are eligible for nursing home care. I always like to make that point because I think people forget that just because people are in a community, they may not be at a level of acuity that you think is needing a lot of services, but these are individuals who actually do qualify to be in a nursing home, but they choose to be in the community with supports rather than being in a nursing home. They can get personal care, they can get private duty nursing if they meet the criteria, they can get assisted technology, environmental modifications, and respite and adult day healthcare services in that waiver. So again, I'm happy to provide more services on no more information on waivers. If you need it, just let me know. Next slide. So we do have a few programs. I talked about arts a little bit. I talked about PACE and what PACE is a little bit. We do have a couple of new PACE sites that are hopefully coming up. And we have one in Northern Virginia and one towards Southwest, which is very exciting. We haven't had one in Northern Virginia for a while. So we are we're keeping our fingers crossed that October and November bring those online. With COVID, it has taken a little bit longer to get those sites certified. But we are still hopeful that's going to happen. Arts, I'd already talked about, and we have lots of information on arts, and we will send that out and give you some ideas of how the number of members who are receiving services have increased drastically, as well as the providers. It has just been a true testament to what we can do when we actually used evidence-based practices and pay for the services that we want. And that is kind of our model for doing Bravo, which Karen's going to talk about later, and changing our behavioral health system to match what we did with arts. So early intervention, another service that's near and dear to my heart. I actually started this program when I was in maternal child health. And this is a service for 0 to 3, so babies up to toddlers, and they can get services like PT, OT, speech. I know that sounds weird for some people. You might not think that that's necessary for a 0 to 3. Believe me, it is. It's a really innovative program. All states do this. We do this in conjunction with DBHDS, and it has been a very successful change when we started paying for, again, the services that are available in Part C and in early intervention. When we started doing that back in 2007, that was really a wonderful switch for Medicaid, and providers came on board, and it is a very successful program. Next slide.
Tammy, can I just make one comment about arts? If you go to any national conference and you mention, when they're talking about behavioral health or addiction, excuse me, you mention the arts program, invariably the speakers will say that's one of the tops in the country.
Thank you, Michael. Thank you, Dr. Cook. Yeah, we are extremely proud of how that program was done. And I'll tell you, it was really how we started out. You know, we've always worked with our MCOs, but that was one case where we all sat in a room and just worked through every service, all the medical necessity criteria, everything. Cheryl will tell you, we all sat there, and they were arduous meetings. It was, we thought they would never end, but it really came to fruition, and people got on board. And I agree with you. I know I've been to many national conferences, and arts always gets called out, and it's really good to hear. But most importantly, the outcomes for our members have been phenomenal. So I think that's all of my slides, but I will get those additional one pagers over to Brooke so she can send those out to the new board members and give you more information. You can ask questions if you have them.
All right, so good morning, folks. Tammy, can you hear me?
I can hear you, Chris.
Okay, perfect. So I'm going to talk about Medicaid funding, so we'll quickly transition into that. Thank you for bringing up the next slide. So Medicaid and CHIP, that's Children's Health Insurance Program, are both funded under federal requirements, federal statutory code. It's Title 19 and Title 21 of the CFR, the Code of Federal Regulations, and statutory law. And so we actually receive funds, even though the majority of our funds actually come from the federal government. Medicaid, unlike Medicare, is a state-run program. So we get match from the federal government, typically a 1-for-1 match. So if we put 50 cents in, they put 50 cents in, and we get $1. During this public health emergency that was struck, the declaration was struck last year, back at the beginning of March, retro to the beginning of the year. We've actually been getting 56.2% in federal match from the federal government. That has freed up general funds from the state that otherwise would be put towards the Medicaid program that have helped other programs in the state. So think of it as the FMAP, the Enhanced Federal Medical Assistance Percentage, that 6.2% has been is a mechanism that the federal government utilizes so states can preserve their general fund. And they know that states, especially when there's a recession occurring, which Virginia, as well as many other states, were experiencing, when the initial shutdowns occurred, that they need those resources to basically buoy up sales tax and other taxes that they're not able to collect as a source of revenue. And so since that last year, we've been receiving 6.2% FMAP, which has again brought hundreds of millions of dollars into the Commonwealth in general fund. And so that's how we pay for our member care services. Next slide. So when we look at enrollment versus expenditures, enrollment's on the left-hand side and expenditures on the right-hand side. As you just heard from Deputy Whitlock, most of our expenditures are on that roughly 250,000 folk population that is in our complex care population. The rest of our folks, so the 1.5 million total, delta there, like 1.3 million folks are in our medallion program, do not cost the lion's share of dollars. And obviously this makes sense. These people have complex needs. They require complex care as a result of that. So most of our expenditures go to support that. And then if you look down there, I mean, 49% in the green, that's our LIFIC, that's our low-income families children population, that's in our M4. They only account for about 18% of our expenditures. So if you actually want a really good glance at how much money we're spending, we actually publish something called an accuracy report. Lauren can talk about that in a second. We publish it in 2 locations. One, we're required to submit a report monthly to the General Assembly, and so you can find that online. It's a little difficult to find because it is a GA website and it's sort of buried in there. But a better location you can find that is on our website, our DMAS, our brand new DMAS website. And Lauren's team actually constructs a dashboard that helps us present that information. So it's a really good source to get monthly how much we're spending on all of our managed care fee-for-service programs, hospitals, all the breakdown of all the funds that we get. It's important to note, just as we mentioned a little bit earlier, that while the majority of our members and our expenditures are in the traditional, what we'll call base Medicaid, which is that 50-50 match, for Medicaid expansion, we get a 90-10 match, which means we get 90 cents from the federal government and we put in the 10 cents. Now, the 10 cents doesn't come from the general fund. It comes from taxes, or we like to use a nicer term, a softer term, we call them assessments, that we assess on 69 private acute care hospitals in Virginia. And so that we collect that tax from them and we turn that in as our state share. And so that's how we collect the 10% right there. And that's a very complicated program because in addition to that, in addition to just the revenue we collect from the state and the revenue we get from the hospitals, we also do non-traditional, non-claims-based payments that are called supplemental payments. And we do supplemental payments to essentially almost every provider type in Virginia. And we provide hundreds of millions, if not over $1 billion in supplemental payments annually to all of our providers, hospitals, certain nursing, certain non-state government-owned nursing facilities, our type 1 hospitals, so right across the street, VCU, down in Charlottesville, we have UVA. Those are teaching hospitals. We also have other hospitals, EVMS, CHKD, that we do a lot of the supplemental payments as well as physician group payments. Again, those are supporting hospitals where they typically see a disproportionate number of Medicaid patients, typically greater than 14%. And so we make supplemental payments to them. So we have different financial instruments that we use to make these non-claims-based payments to support providers that essentially serve more of our patients. And that makes sense intuitively. If they're going to provide more support to our patients, we need to provide more financial support to them. That's just, it's pretty straightforward. And so we have a whole work unit in our provider reimbursement team that does that. Next slide, please. This is actually looking at our total budget mix. Again, it's approximately $16.8, almost $17 billion in medical care. Again, that's everything soup to nuts that Tammy talked about, that you're hearing Karen, all of the medical care, the health access care that we provide to our almost 1.6 million members. That's the $16.8 billion right there. The small little pie wedges there reflect our admin services that we have. So we have 2 admin budgets. One is $276 million, and that's for our agency operations. So we literally just have little over $250,000 to, or $250 million, 276 million, to support our agency operations. That again pushes through $16.8 billion annually. We also have another pot of money. It's a little bit smaller. It's about $50 million. And that's what we use to fund a lot of the carve-outs that Tammy mentioned. So we have Magellan Behavioral Health Service Authorizer. We have Logisticare, our non-emergency medical transportation, DentaQuest, excuse me, which does our dental. And so that's where we posit and place all of those. The last bucket of money that is again unique to the time space that we're in because of the public health emergency is our coronavirus relief fund, our CARES Act relief fund there. Our agency was awarded $238 million for 6 different projects. We've touched on some of them already. The biggest lion's share of that was the nursing homes, long-term care pool of funds. And that made sense. That's where most of the folks actually, if you recall back in the beginning, that was the front line of the pandemic where we had most of the infections and negative impact and morbidity and mortality in the when the pandemic first rolled out in our nursing facilities. So that was provided there to assist them. We also had 5 other projects. They were related to day support, group homes. We also passed out PPE to all of our consumer-directed personal care attendants. And of course, the last one is escaping me.
Hazard pay.
There we go. I knew Tammy was going to run. That's Tammy's. Tammy has been the stalwart leader of our personal care attendant hazard pay. Do you want to? I'll cede the floor a second, Tammy. You want to speak about that? Because I really actually think that's a really important, probably one of the most challenging ones. If you want to speak on that a second.
Yeah, I would agree that it was. We were able to pay. I think it was something upwards of 183 agencies for hazard pay for their attendants in the agency directed model, as well as the attendants who worked in the consumer directed model during a certain period of time last year. It was early on in the pandemic. And so, yeah, it was quite an interesting ride to get all that information in. For those of you who don't know, we don't gather information on attendants, specific attendants who are in the agency directed model. So that is really, the agencies hire them and we don't see that information. So we did have to get all of that information in from all of the agencies who wanted to submit it. So Chris is right. It was quite an interesting ride, but we got such wonderful remarks about that, that how much it helped folks during a very difficult time. So very, very glad we were able to do it.
Chris,
thank you.
I have one quick question for you on this. Do we know where that 1.8% on administrative costs is relative to other states? And Medicare even was considered one of the most effective administrative programs, just 3%, I believe.
Yeah, so we're
we
actually
the does more with that?
Yeah, and in fact we do, and we're a very lean organization. We do not have fluff. We only have 530 classified employees that we're allowed to employ at DMAS as classified employees. And in fact, our salaries only, and you'll see in the next slide, account for a very small amount of our spend. Most of it on administration is contract spend through to support. I mean, as Tammy and Cheryl will speak, and certainly Director Kimsey, our managed care contracts are probably one, if not the most expensive and complex contracts in the whole Commonwealth to administer. And when we have almost 1.6 million people in Medicaid right now, monitoring that and making sure that our providers are taking care of our members, the complexity there is tremendous. And so I won't speak for Director Kimsey, I'll let her speak there. I think we're lean, maybe a little too lean. Director Kimsey, did you want to speak into that?
I think we have been working very hard as an agency to demonstrate there's a perception has been for some time and it really became more obvious during Medicaid expansion discussions where there's a belief that the program, because they feel that it's fraudulent on the medical side, that somehow it's mismanaged on the administrative side. And we actually had a long battle for many years, like 10-year plan to demonstrate that the program wasn't broken enough to even discuss Medicaid expansion. So there's this belief that we've had. We've also been just recently, and we're a very open book. We are comparable to other Medicaid states, although we, as Chris is saying, we're leaner than some of the others because it depends on the administration, and if the administration feels like, it supports. So one of the things we're working on is we do a yearly report about our administration work and changes in how the agency is organized. We literally have to report to the General Assembly if we give any type of recognition, if we shift positions, anything that we do. We are so micromanaged at this point. But having said that, we are a publicly funded program and we are public servants to a significant amount of taxpayer dollars. So we are fine with that. It just is we're under tremendous scrutiny on a constant basis. And we're constantly filling. We're at a very small low fill rate right now. We used to be a little bit higher, but the team has worked very hard to do that. So we have a mighty team. I would say tiny, mighty, but almost 700 people doesn't sound very tiny. But when you're running a program of this size, as you can tell, it's a pretty small number. But we're very proud of the people who are here at the agency, a very dedicated workforce committed to the program's mission and goals.
Michael, could I ask a question? I was interested because as the presentation was happening, I wondered, Karen and your staff, what are some of the major challenges you see? Because with this new normal with COVID and moving so much to technology and what we do virtually, I wonder if you're not going to have some different people on board to move you forward in some of those areas. So I wonder if there's particular challenges that we as a board could advocate for in the future.
Actually, it'd be very helpful. One of the things we've been working on, though, when we said we don't have sufficient staff or for this piece, and everybody go, even our administration will look and go, well, it looks here like you have 20 openings. So why don't you use those? They'll just go in because we're so open and transparent. You can literally see from month to month what we're looking like expenditure wise. So they'll literally go in and look at that. What we could probably use your help with is helping us to tell the story that just because we have those vacancies doesn't mean that we're flush with positions. Another thing we're working on, and as part of Project Cardinal, Greg, is helping to tell our story and making sure as we have shifted to a primarily managed care system, that our agency is right-sided, right? That we were fee for service for many, 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 many years. And so as we have migrated over, we are doing internal business review processes on various divisions and areas to see if their roles and functions are still current and relevant to the work that we do now. And we have been steadily adjusting and flexing and flipping roles. For example, you're so correct. We are now working to create people who have expertise in telehealth because it is such a big area now for us to work on. It was like a single person working on it in one division at one point, and now it's this huge initiative that happened as a result of COVID, which is the single largest piece of people tell us was the best flexibility we gave during COVID. And so now that it's here to stay, now we have a whole team that we're flexing. This is a great example of having to shift expertise and knowledge and grow more than just like one person understanding and telehealth. So we've had to flex and shift for that, but I hope that helps on that end. But we're happy to share with you the latest administrative report if you'd like to see that.
Sure, that's helpful. Thank you.
Mm-hmm.
Yeah, and Karen, if you could keep us up to date as well as you're able to without looking under the political circumstances with what would help as we go towards the legislative session.
Thank you.
That'd be helpful.
I think for us, and it is upon us to say the responsibility is ours, as well as to make sure our administration and legislative members feel comfortable, know and understand that where we are staffing wise, and when we ask for another position, that it's a real genuine need that we have. And so you'll see, as Chris was talking about, we have worked very hard. It's a beautiful, beautiful process and system in place where we closely watch our administrative dollars down to the penny. Every month, we're sitting and reviewing it with the leaders, talking about where it is, giving permissions to shift funding here and there. And we will come down to almost $0 spent, like remaining this year. So part of it is our responsibility to be more that transparent and open and making sure we have our due diligence in place so we can share with you, okay, we spent this, we do not have extra money just sitting out here that can be used for that. We actually need this. And so we'll give the information for you all to help us if there are new initiatives underway. For example, Project Bravo, a huge initiative for behavioral health. Eventually, as we add more to this evidence-based practice system, we're going to need more staff, you know, to help oversee that as a pretty critical process. So deciding like what that need is and then sharing that with you all so you can talk about that with others. Another prime example, and that's just administratively, but we can also talk about other service needs that you can talk about too and support us on as we move forward as well. And I'll mention that one in particular, and I'll mention in the priority initiatives, is dental. We are so excited to offer the benefit, but the rates haven't been increased since 2005. So we're working on that. That's next on our priorities to update what would that look like to actually fund it at a rate that would be acceptable to dentists in current practices and reimbursement practices, and then presenting that to the administration and the legislature.
Yeah, I mean, Greg's question was terrific in terms of keeping us up to date on how to help.
Yeah. Well,
I know we'd love it.
And I appreciate what Karen said about this is a time where you have to have flexibility and adaptability. Things are changing so quickly. Yeah. And I know in our operation, being able to move quickly and being able to adjust your staffing, as you were talking about, Karen, is I think something we could say to legislators is even more needed than we've seen it in the past, probably.
Thank you. And we're very pleased to report there was a period of time, it was very intense in the agency, and we were bringing up the large benefit with expansion. There was a lot of shift and change. We at one point were well over 30%. I think, Sarah, you could let me know in terms of we were losing people left and right. And so we had to do a lot of hard work internal. And part of that also includes our DEI, diversity, equity, inclusion work. And I can talk a little bit more about that in the priorities. I'll find a way to squeeze in if we have time. It looks like we do. We have about 45 minutes to address some of those pieces to help prevent losing our staff in that way. But now I think I'm pleased to report we're down to like 3% in terms of turnover.
That's good.
Which is really important because the team we have here is so highly skilled, the most highly skilled groups in the Commonwealth, they've told us. Average person being hired is at least a master's degree, even in the lower level positions. Because it's so advanced and requires such technical skill. We're a health insurer, so it isn't, that's where we're trying to work with people and help people better understand that the competition that we have with health plans and other large health insurer companies. We lost somebody just this past week. They offered like 40,000, 50,000 over, I think it was almost 50, and we couldn't even come close to touching it. And it's it's just state salary versus, but the work we do is pretty intense at the agency. So we're also working hard to how we do a proper balance on work life for our staff, as well as make sure we get through all the initiatives underway. And thank you, Chris, for that. Actually, this is a nice segue into the priority initiatives. We have so much to talk about with you all and share. I think, with COVID in particular, we were working on initiatives, and of course the pandemic changed everything for all of us, but in the agency itself, and you can move on if you want to the slide deck, thank you. We were working on these other initiatives that I'll bring up to you, but in COVID, and I don't recall there's like a specific slide related to that, but I do want to mention to you all, we did have a pause for a while to address that because we had to implement and wanted to best take care of our members and the providers who support them. We implemented over 84 and changes to the program and the benefit alone to make sure people got in and got the care that they needed and got it quickly and then supported them along the way. So that took a lot of our time, almost all of our time last year, just like for you all, but it was definitely a labor of love. Now, we've been working on some of these initiatives, and please ask questions along the way through this, because this is really like the team. Thank you, team, for doing a beautiful job. They're like the overview. And here's some of the great work we're doing to continue to enhance and reform and change. So change the things that you saw earlier, a lot of the hard work being done. Program there are a lot of areas in existence, and Chris and his team have done amazing assistance at helping us show this, tell the story financially about programs looking. So now our attention is on like care, and people they're receiving care or applying for and getting into the program. And you can see the governor has declared this a priority.
Karen, you're breaking up.
And we, follow. Yes. Oh, okay.
Yeah, you're breaking up.
I'm not. Oh, hang on, real quick. Let me. I'm gonna see. Hopefully, this is better. I'm sorry. I may have been on VPN. It may have caused it. You can hear me now. Sorry. Love the internet. Okay, so I had to disconnect myself from our VPN attachment to the agency. My apologies. But we are very excited about the maternal and child health initiatives that we have underway. It aligns very closely to the governor's initiatives to improve maternal and child health and mortality in particular for women while they're carrying and also just after having babies, and of course our babies. We love our babies. And so 1 in 3 babies born, if you're not sure if you know that, are on our Medicaid program. So we're very, very proud of that. So you see these initiatives. We have a lot to do, still more to do, because the average, I'm not sure if you're aware of this, but when something happens to a mom or a baby, it's usually within the first year of life. And so the problem for us for a while is for a lot of our pregnant moms who were enrolled because they were pregnant, they lost health coverage after 60 days. Very pleased to report there's an initiative underway now, directive to us to expand coverage from 60 days to a year for women having a baby. And so that'll help carry them through those really critical periods along with their babies, because we want them to all celebrate the first birthday together. And some of these examples of what we're doing to help make sure that happens are here. Tammy had mentioned, I mentioned the coverage of 1 year postpartum. We are expanding treatment, the addiction and treatment services to FAMIS Moms program. A big one too with doula services for pregnant members, and that will come in the fall. Coverage of prenatal care regarding of citizenship status. That's also another federal drive that's coming for us on the way here. Looking at developing a home visiting benefit as well. So the team is working on that right now. And we're also watching closely our HEDIS measures and scores in this area for our pregnant moms and babies, and we'll be targeting that and working with our health plan partners to help improve these scores. So very excited about everything underway here to take care of our moms and babies. And of course, you're going to see some changes in our slides and graphics as we move forward, because one of the things we're doing in terms of addressing equity out in the system and in our programs is we want to make sure we reflect our membership in our slides. So you'll see a lot of people, different diverse backgrounds and education. And we'll also have the team, Christina, I'll see if we make sure we can get Craig and team folks to share a copy of this with I think we'd sent this to the board members before, but this is a new, improved hard version of Faces of Virginia Medicaid. So we talk about, and we'll make sure you get copies of this, but we talk about pregnant women and children, but there's so many other faces that we see on here that we're working on addressing. So we click to the next slide. We're also continuously working to make sure that it's not just enough for us to make sure we have this service here, a benefit there, make sure that rate's up. We have to make sure that the care that we provide is understandable, accessible, and usable to our members. And so we've embarked the last few years on a very significant effort to make sure our member notices and letters are understandable and easy to read, and make sure they know what their rights are related to the program. We've developed a language plan that addresses how we're going to communicate to our members in different multiple types of language. And also our engagement strategy. Very, very pleased and proud and love to have you all involved with this as much as possible. And our member advisory committee, now entering our 3rd year with a new membership group and committee. We just had that meeting, and it's a very, very, and Michael, thank you. I believe you were there in attendance, and you are all welcome to attend. And that's another thing, it's part of this orientation. When we're having meetings and they're public, or even if they're not, just internal inside, and we're having different pieces, you are always welcome to come and join us at any and all of these meetings and be an active participant with us here. And Michael does that quite a bit, our board chair, so we're very happy to have him with us. But we are also very eager to make sure that people gain access to the program as well. And so one of the last ones you see that we're talking about here are that 40-quarter work requirement was eliminated in April of this year. Very, very proud, very excited about this. 4,000 individuals who have green cards are now eligible to apply for Medicaid. So just one more, it's just like chipping away at this just a little bit, but always in the effort to try and improve the program, make it to the best that we can for our members. Also, in appeals, for particularly individuals who have advanced medical needs, it's called de novo. So if you appeal a decision made, you have up until the time of the hearing to present additional information and evidence. Okay, not quite sure. Maybe I won't move as much. I'll try not to. Perhaps sometimes the screen gets upset when you move. So I'll try that.
Karen, you were doing,
next slide,
Karen, your
please.
bandwidth was great. Can I make one quick comment? I can't advocate enough for our members. If you have a chance, just attend at least one members committee meeting. It places you in touch with our beneficiaries, which I think is really critical for all of us. We got to remember why we're here.
Absolutely. Can you guys hear me okay now?
Yeah.
All right. So I'll try and be very slow in my movements. And I just turned off every electronic device around me for Wi-Fi. So hopefully that'll help. Just never know. You don't realize how much they suck energy down until you have too many devices open. And we all have a lot of work and personal devices around us now since we're Zooming and teleworking. So looking forward to that. Also, as we move forward to this and telling you all, you're probably aware, you can see us, we're not in the building just yet because it was a private building. And so it took quite a bit for us to be able to migrate back in. But starting in June, we're going to be easing back into building. Some folks are already in the building now, but for the most part, you'll start seeing more of us in the building. But we are also working hard. So we were just talking before about our members and things we're doing to make sure our members have coverage that they need. And in case you weren't aware, during the public health emergency, if you're enrolled in Medicaid, you can stay on Medicaid even if your status changes through the end of the public health emergency. So that is another nice guarantee for an individual, at least not to worry about their health coverage during the PHE period. But another thing that we've been working on and doing to make sure our members' experiences are better is we just recently, we were authorized by our legislature, through our administration, to extend for 12 months of coverage of contraception. So a lot of evidence is showing that if women have this readily available to them, that they're much more likely to be compliant with taking it when they need to, instead of having to worry about going to a pharmacy. So that's a huge plus, a benefit to our members. Also, telehealth, as just mentioning, is here to stay. So we're working on developing proper guardrails for that. And we'll have more to share on that. And Greg, are there any questions or thoughts you may have on that one?
I think it's interesting to see how that's changing so quickly and implications. And many from families, I'm thinking not just telehealth, but telemeetings. I think many of the families that we're working with appreciate those being able to use telehealth as an option.
They certainly do. And I apologize real quick. I hear that I'm going to close a window. I'm sorry, I'm just filled with little fun adventures today with teleworking. But you're right. One of the things that the people cutting the grass are here now. So one of the things that we've heard, Greg, you're right on target, especially with our MAC, our Member Advisory Committee, is for people who travel. It is so nice for them to just have the convenience of calling in. Also, we had a significant increase. Behavioral health, people actually were able to, that was one of the services, Tammy, correct me if I'm wrong, that did not significantly drop, exception of therapeutic day treatment for children because the schools weren't open. But other behavioral health services did okay because the telehealth option was available to them. As a matter of fact, it grew quite a bit and we also saw, because of telehealth as available option, fewer no-shows to appointments, which is an issue. At least 27% of all appointments made by Medicaid members result in no-shows. And so somebody was like, yes, is that you, Dr. Cook?
Yeah, that was me. This is Dr. Cook. So we implemented telehealth in March of last year, and it has been a survival link for our federally qualified healthcare center that those audio-only visits are covered, as well as the audio-visual visits. We have so many patients who don't have data plans that allow for an audio-visual visit, but can handle an audio visit. So it's made a huge difference, and it has decreased our no-show rate, and our behavioral health services have stayed fully up and running throughout the pandemic. And they've been 100% remote until this month.
Great. And so that's an example of where we see the huge benefits. Obviously, it's here to stay. Figuring out the audio versus visual, like in terms of long-term, right now it's the same rate during the public health emergency, but we will likely adjust the rate to reflect it audio only at some point. But even our federal partners haven't quite figured that out yet, but we agree, huge benefit, especially like for seniors who are uncomfortable using smartphones. An audio phone is definitely a way to go. I've had several appointments that way, and it's been great. So totally understand and appreciate that. And what a unique service we saw an increase in, which we thought was interesting. We're diving into it more. Dental has been growing in terms of consulting. And so just that was an unanticipated increase that we saw. Of course, we thought primary care, behavioral health, some types of hospital supports, but it was very interesting to see dental care, and that is not atypical. We're seeing that in the nation as well. So as you can see here, the remote patient monitoring is another part of the telehealth approach. We received approval and funding to add that. So we're very excited to have that as a new benefit, a new component to our benefit. Also, pharmacists can now give immunizations, including the COVID shot. So that was a huge change that we had here in the Commonwealth in general, not just to the Medicaid program itself. So another way to help reach our members and also provide some flexibility and control too in areas where maybe it may be closer for somebody to get to one of these places instead of to their primary. Also, we are moving on to tobacco cessation, just all different types. Tammy already touched on addiction treatment beyond opioids. So we are just moving and shaking on all of these different types of initiatives. All right, keep going. Other ones. So, I laugh because we used to, many years ago, I've been here 26 years almost now with Medicaid, and we have seen a lot of changes. And it used to be in the years past, we'd have 1, 2, maybe 3 big initiatives. We are on average running 10 plus initiatives at any given time. And we have a list called our priorities list, and it has over 100 different projects running right now, even just in the agency alone. But these are some of the big ones that we want to talk about with you. So we have our Medicaid Management Information System. It's the monolithic system that drives our claims payment, member enrollment, provider enrollment, all the main central hub systems to run our program. And it's being updated to reflect a new system called a Medicaid Enterprise. It's the same system, only it's being chopped up into different modules, 11 different modules, so the same functions, but in their own distinct little modules now. And we procured for each one separately instead of one company. And we are very pleased to say that we are on target to implement all of that by next April. So a lot of hard work on the team, but it also has implications for us as the year comes in the next year, because as we roll into the new system, we'll have to what we call hard freeze on any changes coming. So that's also a point to educate you all on, because people are very excited and we love making these great changes, but we're going to have a window of time where we're going to have to pause on making any systems changes. So anything new coming down the pike will have a longer period to get launched until we can get this up and running. And we'll provide you with more information and a timeline on what that will look like. The team is working on that now. So if people ask you as your capacity as a board member, what do you think about this initiative or that new one? This will be in the top of your head to remember, oh yeah, that's right. Medicaid's going to be freezing it for a little period of time. So maybe not suggest anything new go live during that period. All right, so we appreciate your help on that. We're also in the process of merging our managed care programs. We've been directed by the legislature with administrative support to take Medallion 4 and CCC Plus and merge them into a singular program. So that will happen by July of next year. And we're well underway, and we had the next board meeting. Last board meeting I talked about it, but we'll also continue to provide updates to you. We are working on a new call center now, the Medicaid call center that just went up. We've had all by developing one number for people to be able to call. So we're very excited about that. We've launched new websites for the agency itself, as well as for Cover Virginia and Cooper, Virginia, which is our Spanish website. And also all different types of improvements. And talking to you next, I do believe about Project Bravo. Actually, Bravo will come right after the dental benefit. There we are. So we talked about this a little bit before. Very, very excited about having this. People have been waiting for this to start since we did the children's benefit way back when. And so as you can see, we're moving steadily ahead. Its effective date is July 1. We don't fully expect that dentists will be all on board enrolling and exactly at that moment. So it's going to be a continuous process to bring this up. As I mentioned earlier, there's a lot of discussion out on the scene. They're so excited about this. Dentists are encouraged and excited, but they're also talking about the need to bring up the rates. So you'll likely hear a lot of that over the next year, but very, very pleased about this. Okay, next slide. The next one is about Project Bravo. And we mentioned to you, we have a significant behavioral health system. Oh, sorry, it's adult dental. Here's more. I'm on another dental slide for you. So again, we're very happy to have that. Just as you see the 750,000 adult, that's because the other remaining members already had that type of coverage before now. But here's another big initiative that we have underway. Very, very pleased to talk about this. It's Bravo. So we are developing in the community now, revamping the current system we have into a more evidence-based model of practice. And Tammy alluded to this earlier, and Greg, we know that you know this too, is that people, when the system was first created, it had a series of assumptions as to where people actually received mental health services. And maybe at the time back then in the early 90s, that may have been true, where the lion's share of people went through community services boards here, the equivalent of the mental health centers in other states. But the reality is, and doing a study done by the Farley Center based in Colorado for us, is that individuals are touched for mental health in all different places. They go to their primary, they go to their schools, and that's where the lion's share of services, and it's not the community services boards, which are less than 20% of expenditure services for our population, it's the private providers. Now, don't get me wrong, we're very supportive and encouraged and right there, Step Virginia, with the CSBs and supporting that critical system of care. But we also know and understand we have a significant network out there of private providers who supports us. And what we're doing now is the first step is in July. It's our first phase where we're updating and shoring up existing services. So the first ones we're going to talk about are assertive community treatments. They call them PACT teams. Those are being updated to reflect new rates and expectations for an evidence-based model for higher payment. Also, we're updating partial hospitalization and intensive outpatient, starting there and then moving into the next phase of other different types of services that you can see in this beautiful continuum across the lifespan. We want to expand a service delivery system to meet people where they are in the community. And the institutional level care is still there and available to them, and definitely an evidence-based practice. But we want to make sure that before they need that level of support, to make sure that the level that they truly need is in a community before it escalates to that, which we have an issue here because our system was heavily built towards crisis and institutionalization. And so now we're realizing, hey, because the community services never really surfaced or were properly funded at the time. So now we have full support with stakeholder community. We're very excited to be making it forward here. And as we move forward and touching the rest of the system, adding more evidence-based services to come, we have full support the General Assembly, the Deeds Commission, which is assigned SJ 47 to pay attention to these particular issues, is all on board, full support and endorsing this move. And so we are very, very pleased to have a very talented team here led by Dr. Alyssa Ward under the leadership of Tammy to help bring this to light. It's called Project Bravo. If you just, so you're going to hear a lot of it. We used to call it behavioral health redesign. There was a gentleman, his name was Dr. Hughes Melton, and he was commissioner of the Department of Behavioral Health and Developmental Services, and he died unexpectedly. But he was one of the big champions to this and was a huge, a good friend and also very significant champion for these types of changes, and was standing side by side with us, helping to move this forward when his unfortunate death happened to all of us. And so we honor him by naming this Project Bravo because he used to fly a plane. And he flew a tiny plane, and he was used to fly it into Atlanta airport, which was considered very brave by a lot of the people, because most people with little planes won't fly in there, but he would. And so he got nicknamed Bravo by the air traffic controller. So this is an honor for him to do that. So wanted to share that with you. But we're very, very excited about this. And as we move forward into this, there are also federal opportunities to pull down enhanced federal match on people who are ended up inpatients right now. They call it institutes for mental disease. I wish they would change that. But it's a psych facility hospitalization, essentially. And if you're a certain age between 21 and 64, we can't pay for that. Right now, federal rules, unless you're like in managed care under some limited arrangements, can be done. But outside of that, we can't pull those federal dollars to help cover that. As we move forward to the more evidence-based model, CMS sees us making those steps towards it, just like we did with arts. They will talk to us and we can engage with them to get an 1115 to help pull those dollars down to help continue to shore up our system. So we're excited about that and have a lot of legislative support for that as well.
Karen, if you need any background on the IMD stuff, the one legislative set of acts that I was involved in that generated a major study on whether to get rid of the IMD exception back in, I guess it was back in the 90s, late 80s and 90s. I'd be happy to chat with Tammy or whoever it makes sense on. There's some really good material there, and whether they got rid of it or kept it literally involved who was getting the ear of the person in the central office. And at the time that Clinton was defeated, rather that Clinton went out and Bush came in, I believe it was that one. But whenever you have as you know, whenever you have the other party coming in, you kick out every piece of controversial material you can to shove it on them. and we came very close to getting rid of the IMD exclusion, at least for where you were talking about less than 15-day average ALOS, average length of stay. Anyway,
Well,
I'll
hopefully,
shut up now.
No, thank you. I mean, and hopefully, maybe what would be ideal is to get rid of that restriction altogether instead of requiring states to do enhanced 1115s. That would be the ideal piece. I mean, it really, I would call it an old Jim Crow law. It discriminated against people with mental illness. And so we're steadily chipping away. I call the 40-quarter work requirement also an old Jim Crow law. It's there's statutory laws that discriminate. And so we're steadily chipping away. And hopefully, if there's any effort on Congress and the administration to get rid of that we would warmly receive that versus having to negotiate cost neutrality for waivers. I mean, it really can be quite cumbersome. So
got to be more nuanced, Karen. It really came out of the state warehouses. The state warehouses when we used to throw people into state institutions and keep them there forever. But anyway, I'll shut up now.
Yeah.
Karen,
yes.
I just wondered about Project Bravo, and I'm sure we'll be hearing more about it later as it develops. But I know one of the things that was happening, because of course we've been involved in this for a long time too, in some of those services. But I know it was really tied to system of care. So it wasn't just what movement was going to happen with DMAS. It was with the Department of Behavioral Health. It was with the Department of Juvenile Justice. It was with DOE, and it was with Children's Services Act. My assumption is that those groups, and I know we're also looking, we've had a delay in the Family First Act with the Virginia Department of Social Services. But my assumption is that all of these groups will be working together. And I know we lost our System of Care grant, the SAMHSA grant, just ended with Department of Behavioral Health, but there seems like there's still a move to keep that focus going.
Oh, absolutely. And my apologies for not mentioning the significant stakeholder work. I was just trying to be mindful of our time that you are absolutely right. And this is all being done in tandem with our partners, with the Families First Act. All of these services are being calculated and done around the same time to complement and support all the initiatives. And we are in lockstep, seriously, with CSA, with the Children's Services Act groups where, sorry, I'm trying not to use acronyms for the new folks. The Department of Behavioral Health and Developmental Services, I can honestly say there, you may have heard years ago that there were like differences of opinion or maybe the agencies didn't get along. That is absolutely not true now. We are strong partners and are moving the system together with you all and stakeholders who are in agreement this is happening. It really is like the perfect time the stars are aligned to do this.
That was my sense. The Children's Cabinet, I think, has been pretty strong too. And I just felt like it was still, moving forward. I appreciate you saying that, and would love to hear more as that develops.
Absolutely. As a matter of fact, and Greg's referencing the statewide executive council, of which contains, leaders and key stakeholders to look at children's services and make sure they're getting the very best that they need. And Secretary Carey chairs that meeting, and he has the agencies and groups regularly update, and we're in tandem together on those topics with the particular laws in place and how we're all working together on that. So a lot of work, a lot of concentrated effort, and Tammy and her teams are very involved with them.
Yeah, thanks, Karen.
So a particular note, remember that report I mentioned, and just to highlight it to you on this slide, there's a link, the continuum proposal, which actually outlines what the system was looking like at that point and then where it could go. So hopefully it'll be a helpful resource for you as you move forward. Also, one other slide, just want to move on and talk about real quickly, and then just leave it open for people to ask more questions for us. Cardinal Care, I'd mentioned it earlier, Project Cardinal, which was an initiative to merge the programs together. Because, like I said, we are primarily managed care, we want to make sure we're as open and transparent as possible for the program and its operations, where we've worked really hard to be open and transparent on our finances. And we already have lots of information about how our program runs. excuse me, but we want to present more, provide more in a very open and very user-friendly fashion how our program is running on the managed care side. We also want to take opportunities like we just talked about to streamline our processes and improve them as much as we can. Can we be more efficient, even in the agency, and how we operate and run? And so this project carries us there. And another thing we're doing is rebranding the program itself, because the term Medicaid has a lot of stigma still in our system from where people expect that or do not feel they're entitled to, could receive it or want it. So one of the things we're doing, and people get confused with what programs they're in from time to time, so we're going to name it, the entire program itself, Cardinal Care. And we're working on the logo, and once we can get that to you, we'll be happy to share that with you. But it will all be, all the programs will be under the umbrella of Cardinal Care. So that means if I'm enrolled in the Medicaid program Virginia, it would be Cardinal Care or Cardinal Care Virginia. And I won't have to worry about if I'm in Plus or I'm in Medallion 4, if I'm in PACE. You know, it'll just be Cardinal Care. Hopefully it'll be easier for people to know and understand that way, and also the stigma coming away with that. But we are very excited. As I mentioned earlier, we're aligning our contractual requirements to be more simplified and easier to understand, and also accountable to working with the health plans, and also for our stakeholders to see that as well. And it also enables us, because right now we have to set rates for 2 separate models of care, and which can be, you know, quite expensive. We're hoping to be more streamlined to create one series of rates. It's still the same, different population models, but instead of having 2 separate processes, it'll just be one, and similar things like that, where we're hoping to be more efficient. And also for the member, the transitions could be quite difficult. If I were in 4 and I shifted to Plus, but I changed plans, then that transition could be challenging or difficult sometimes. Or if I were coming from fee-for-service into managed care, we're looking into making that process easier for members. This streamlining into one program will also help make that a little easier for members as well. We also want to make sure that the care management models that we have in place for our specific members are right and where we need to be. So we're going to be looking at and working with you all to help review that and align that to be the best that it can. So I'm just very excited. And Turn-Ons, when you see here a piece about the medical loss ratios right now, just to explain that both we have 6 health plans that were for the regional managed care work that's done, but they each have a different medical loss ratio for each program, for either Medallion 4 or CCC Plus. So this program will combine both of them, because we've had experiences in the past couple of years where they had additional costs for long-term care or maybe advanced behavioral health needs, and they had took losses in CCC Plus, but then had surpluses in Medallion 4, but could not use those surpluses to offset their losses. Instead had to turn it back into us, and then we had to shore them up on the other side for their losses. So this will help combine to just one MLR for the entire program, and it will give more flexibility to the plans. Now, just so you know, that check and balance of the 3% cap for profit is still there and will not be changing just because it's one MLR. That will still remain. But this is a lot of what we're doing over the next year to 2. So as you can see, we're not just resting, we're continuing to move forward and change and adjust to try and make it as efficient and effective as we can to deliver the best care for our members. And that's where we always keep our members first and focused with our providers in these thoughts. But this is where, go ahead, Michael.
Karen, on the MLR, are we doing any work to look at perhaps kind of shared savings program, so that if they save a certain amount of money and come in below, they get it, we somehow share savings with them in some form or fashion?
There are opportunities for that, I believe, for the future, but we have, I wouldn't say it was like, we have withholds, and it's not really a shared savings. I know what you're talking about, that if they realize an efficiency, then they get a portion of it back. We are, Chris and team, I do not believe we're quite there yet, although I think we have maternity kick payments. If they're positive outcomes, then there can be a kick payment related to that, or different types of pieces. So that's a closer where we get. We also have quality withholds. We hold the funding, and if they meet certain benchmarks for quality, then they get the funding back. So it's not quite where you are, although we do have different levers that we're using.
Hey, Karen, this is Chris. You're absolutely 100% right. We don't have a shared savings program. We do have, as a result of a JLARC study in 2016, they put into the Appropriation Act, which is like the highest authority, excuse me, that we have to recover profit cap exceedances and of course, any MLR exceedances. That's a CMS requirement where they're upside down. And so we're actually getting almost close to $130 million back from the managed care organizations later in June, just a couple months from now.
And just for folks to know, we attribute that, like some of that, that's COVID too, like the underutilization, Chris. Yeah, so just letting folks know that's not a typical amount being returned in a day. That does reflect some of the underutilization.
And I'll just add, if you don't mind, one of the reasons that we've actually gone the withhold route as opposed to doing like a full shared savings is that we have a little bit more ability to incentivize specific quality. One of the things if you're doing just a general shared savings is you might have the NCOs realize those savings by, denying services or having additional restrictions. So instead of doing like a more general shared savings, what we've really preferred to do is start to target some specific services, some specific outcomes, so we have a little bit more control over what we want that incentive to look like.
Yeah, and even with the shared savings model, you'd want to make sure that you kept your quality metrics in there as a condition.
Absolutely. Well, this is actually wanting to, I guess, flag for you all to see. The team has crafted together on this next series of separate slides, a series of resources for you to review and look at, and examples if you're interested in all the digital types of communications that we're doing right now. I have to say, highlight to Christina Knuckles, who is here on with us, our Director of Legislative and Comms. We did not know until she joined our team. She's fabulous and has really brought us into really a strong digital age, along with our strong IM team, with Chris and his team. And all that we're doing, like with Sarah and her teams, to help get the word out and information out to our members. You can see all the various ways that, like a no wrong door strategy for us related to helping people gain access to health services. And so we connect to them. We're seeing more and more nowadays, the best way to reach people is through social media. And so we've definitely got more savvy with that. Just a quick example, one thing when we were doing Medicaid expansion and we did a launch, we made a quick tweet about one issue. I'm just encouraging people to apply, and within 30 minutes of receiving that tweet, we had hundreds of calls come in. So we know it works. We know it's very, very effective, and just very proud of Christine and her team and everybody for all the hard work in this area. Also, you'll see just examples of our beautiful dashboards in terms of our efforts to be open and transparent. The next one reflects our Medicaid expansion dashboards, and we're working on creating other dashboards. We have other dashboards with finance and others that you're going to see related to this that we'll be developing on the program side. So we're very, very excited, especially I'm very interested in having us with long-term care, our duals, behavioral health services. All the different information will be readily and near real time available to you all soon as we move forward on that. We also have numerous publications. All the resources are out there, all of our board meeting materials. So if you'd like to see previous minutes of our board meetings, they're all on the website, or we're happy to share it with you if you reach out to us and let us know if you have any struggles with getting it. We have all of our studies and reports out on the site. To Craig and their teams for managing all of that and getting that out there. Also, you see our numerous publications that are out there, especially with the team, and you heard me mention a little earlier. I'm so excited. Christina sent it to me, I almost cried. I was so excited to get this this little booklet. So please avail yourselves and look at them and share with them the faces of Medicaid, and all. It's easily for you all to share as you are using in your discussions as well as board members. And also other appendix information just for you to have as you move forward is the various divisions in the agencies and what they do and who they support. So if you have questions or you need any information, we are happy to reach out and help you with that. You can always, if you need something specific or any question about something or would like to be a part of something, please reach out to Craig and or Brooke, and they're happy to get us and get you connected to those areas. And we can also have more conversations about that too, if you'd like a more in-depth conversation or discussion about a particular area or what they do. And I just just want to make sure we have a few minutes left, and just are very grateful to be able to be here and give you a quick orientation. It's a really quick, we could probably do this all day. What many of us do, it's a labor of love, but just happy to give you a few more minutes. And also, this isn't the last time to ask questions about these things. We're always open and available for you.
Do folks have any questions here? Comments, discussion?
The only thing I wonder, Michael, this is Greg, that it sounded like we'll talk more about the function and the roles of the board and some of the board structure. I know we had planned a retreat, but I still don't believe we have a date for that yet. So I didn't know if that was going to be tied into a next meeting or.
No, we have June 23rd. I thought that was sent.
Okay.
You should have received emails and also a request for a response on that, because that's going to be that's critical for all the members.
Thank you.
We're also going to see if we can get the Attorney General's office to give us a little more input on basically the law, the legislative history. I can read the law, which probably, but the legislative history probably was the legislature saying, hey, this would be a good idea to have a board. But to the extent that there's been any analysis, we're going to try and take a look at that a little bit too.
Thank you.
All right. Any other questions, and members of the board?
Just want to thank everybody. This has been tremendous.
Oh, hi.
I echo Razi. I think you guys have done just a phenomenal job with this. If only the administrative services would give you a little more bandwidth, it would probably make life easier.
Well, I do give them credit. Thank you. The legislature recently, we needed to do Project Cardinal and they want us to. We said, could you please give us some resources for hiring a contractor to support us, because we're stretched really thin with everything else we've been directed to do. And they were very gracious and allotted us $2.5 million, which, you know, it sounds like a ton of money, but contractor support's very expensive. And so if you want really talented people who know and understand Medicaid. So we are very grateful. We are feeling the support, but ideally we'd love to have it as FTEs as well for the future. So appreciate all of your support on that area, because it used to be we had enough support, the team, we could actually handle it. But as you can see, we have so many wonderful priorities. The beauty is we have administration legislature that loves Medicaid, and that's also a little bit of a challenge for us as well, because they have so many wonderful things for us to do. We're just a little stretched right now, making sure we get them all done, but we're going to do it.
I can suggest one line for you. When my grandfather was Secretary of Health and Welfare in Pennsylvania, and back in the 50s, and kind of changed the face of mental health treatment there, he had a line before the legislature. He got up there at the budget hearings and said, gentlemen, thank you. It was men at the time, unfortunately. Thank you, gentlemen. You've given us everything but one thing. This year, try money. He got his budget.
I bet.
Yeah.
He did a little work beforehand.
I appreciate the time, Karen, you and your staff took, and Michael driving this to. It's always helpful as a board. There's so much going on, and we hear different pieces at the board meeting, but to have in one presentation put together in a concerted effort was very helpful and a good resource.
Kind of you to say, Greg, but I think this was your idea, if I recall.
It's good when you're coming. I've been on a number of different boards, and it's nice when you can get to know the other members and when you can learn from the staff and begin to develop those relationships, because I think that carries you through your term as a board member.
And also just to the members of the board, you know, as we will slowly be migrating back into our building over the summer and, you know, getting our feet wet in terms of how we have meetings and how we meet publicly with groups. And so we do look forward when we're able to being in person together. I think that will mean a whole lot and also give us time to interchange with you all. You haven't had the ability to do that yet, where we sit down, we offer lunch for you all afterwards, and we just hang out and talk about anything and everything you want for up to an hour even after. So just plenty of time for the members to spend time with each other and talk, and that. So that will come soon, hopefully, when we can get together.
It makes a huge difference.
It does. Well, thank you, everybody. We really appreciate the opportunity to be here with you today. And we look forward to working with you all. Thank you so much for your time and dedication to our program and our members and the team at DMAS. And we really cannot tell you how much we appreciate your commitment. So.
And just a very quick, Karen, just a very quick thanks to.
Yes.
Breaking up.
So Michael, you're the one that's in and out now.
Yeah, to Brooke and Craig who do just.
Yes, thank you. Yeah, huge shout out to Craig and Brooke for helping to organize all of this, as Michael was saying. Thank you, everybody. And take care.
Bye-bye.
Take care.
Thank you.
Have a wonderful day. Bye-bye.
Thank you, everybody. Thanks.